have something that Ben Franklin didn't have when he proposed
No,
this.
I'm not going to be here.
Electricity and lighting.
I'm going to be in Texas.
Oh no, it's electricity.
I can
Just
have
hadn't
Brian
harnessed
present
it yet.
Uh-oh, are we starting?
Was it?
No. But we could call the meeting to order at 5 o'clock on March 21st. Do we have courtesy of the floor?
We do. Very briefly, ma'am. We've been talking about staffing issues at Graysdale since I was sworn in as county executive, and long before that, actually. And one of the things that I think we have to tackle is the 30% of people at Graysdale, predominantly RNs, LPNs, and CNAs, 30% who are out at any given time on FMLA and IFMLA. Now let me be clear. I want people who need FMLA, and IFMLA to have and access FMLA and IFMLA. We never want anyone who has a dying parent not to be able to spend time with their parent and be in jeopardy of losing their job. We never want anyone who has a sick child to have to worry about not being with that sick child in fear of not having their job when they're done. We never want anyone to lose their job who gets ill themselves, and that's why I support FMLA. That's why I supported it when Congress originally passed it. That's why I support it today. That's why I always support its reauthorization. But when you have 30% of your staff on FMLA or IFMLA at any given time, you can't talk about massive hiring ramp-ups without dealing with the potential, the possibility that FMLA or IFMLA is being misused or abused. So, my suggestion is to the administration at Graysdale to form a committee that includes the administration, the heads of AFSCME and the steelworkers, and career service folks who have some experience with FMLA and IFMLA to come together to try and deal with these problems themselves. Employers have rights under the FMLA, and one of those rights would be to have an independent medical examination to test whether the system is being misused or abused. But I don't want to go there. I don't want to go there because I want people to access FMLA and IFMLA who need it, right? Because that's what it's for. It's so important. But we also can't not investigate the potential, the possibility that it's being misused. And until you do that and determine whether in fact it is, I'm not sure you can have any kind of meaningful discussion about staffing at all. Thank you.
Wow.
30%. Okay. Any other courtesy of the floor? Okay. We have a letter that we received from Miss Jana Morris from Recovery Revolution, and there were some allegations, so I've asked Ms. Wondolowski to address it and make it clear what we are or are not doing regarding that matter. So if you want to start.
Did everybody have the opportunity to read the plethora of documents that Ms. Zembo sent you? Okay. Well, it's maybe easiest to start with, if anybody has specific questions. Those documents were long, and so if anybody actually read them all, I appreciate it, because that it's been consuming an awful lot of time. But when it first came to my attention in the summer, I'd only been here about 6 months. So although I had hoped to be able to respond to Ms. Morris within a week or so, which is what I had told her, it took me probably closer to 30 days to actually be able to talk to all of the people I needed to in order to formulate the lengthy memo response to her. And as you also would have seen, my predecessor responded to similar complaints, shortened versions, but in a much briefer capacity. And I just felt like since Ms. Morris had taken such a great amount of time coming up with that length of a complaint and had attempted to make the same complaints to several different people, that she was entitled to a more thorough response. So that was, I think August was my memo. And then in light of the issues that she had brought up in her recent complaint to you all with the grant, that was the impetus for her second complaint, and my Beth Miller's and my response to council. So I certainly can explain that more or differently or again, or answer any questions people might have.
Go ahead.
Maybe we can go from there.
Sure.
I guess it gets to, I'm not going to get so much into the treatment. I went through your documentation and read the history. She had a standard county contract that we normally would be giving out with a certain amount specified.
Correct.
And I got the impression that one of her complaints is that she had spent down that contract and she'd get more.
Correct.
As far back as I can remember, we're not obligated to do that.
Correct.
We're not even obligated to do that for the county departments if they spend down there. I mean, it could be a problem if we don't, but it happened in the past.
Understood.
But, so fundamentally, at least in that narrow constraint, not getting into treatment.
Sure.
That was one of her complaints, that we didn't
Correct.
continue to give her more money, and she said because people were suffering.
Yes, correct. And actually, Beth Miller, and I think I added this to the final draft of my memo to you, any of our providers, at least within the drug and alcohol realm, I'm supposing we do this in all divisions, but I can speak for that one particularly, when the providers are on track to be overspending, even halfway through the fiscal year, we let them know that. And so I don't have the exact dates in front of me, but it was probably November and December that Beth Miller had emailed Ms. Morris to say this is where you're at in your contract, and just want you to be aware. Ultimately, when any of our drug and alcohol providers are getting to the point of spending their entire allotment, the first sort of protocol that we use with all providers, including Recovery Revolution, is to have them refer clients to providers who still have funds left in their contract. Certainly, if there was an extenuating circumstance and we had a conversation with a particular client who, for very valid reasons, wanted to go to a particular place that was already spent, in all likelihood, if we had the funds, we would amend the contract to accommodate that person. But we have not had that happen in this case yet.
Yes, please. Yeah. I have some questions.
I read the letter. I didn't read letter for letter everything that you sent us.
It's lengthy.
Went back years. But I read your letter, and I thought you addressed everything well. And given the fact, as I understand it, given the fact that this individual sent a letter to the governor, and I don't know who all else, but are you going to send your reply to those folks as well so that they understand our position?
I did not plan on that at this point because I don't. There were other folks that were copied on your letter.
I'm just saying. I don't know if it's necessary, but
Would you like us to do that?
Well, I'll let that up to the chairman. I'm just saying. I don't think the governor probably read it. He assigned it to his director of public welfare. But that being said, she seemed to copy everybody in the universe on her charges.
Correct.
And I thought your responses were cogent and well written, and I don't see why we wouldn't share that with the same people. That's you. I'm not asking for you to do it. I'm just saying.
We'll certainly take a look at that.
That's
And the
all
reason that I included the historical documentation is really under the previous drug and alcohol administrator, Mary Carr, prior to Tiffany being the administrator, who's of course now not, but Beth Miller's in Florida. Hi, Beth, she's watching. I don't know why, she's on vacation, but anyway, contracts were done a little differently once Tiffany took over, and they weren't just randomly allocated in terms of dollar amounts. And I'm not speaking for Mary Carr. I don't know how she came to the number she did. She certainly may have had her rhyme and reason. But what Tiffany and Tabitha Gartner did when they were in that division was average the last 3 years of actual funds spent, and that was what their contract amount was. But as you see in the memo, there was certainly a few things that were funded under previous administration that we don't feel would be appropriate for the taxpayers to fund, and so those were cut. And yet, Ms. Morris continues to get funding for some services that none of our other outpatient providers do get. So after that change in administration, there's been a complaint to all subsequent new administration, both to Mr. Brown and to Mr. McClure and myself, Allison Franz. So I just wanted you to see the pattern of.
Mr. Chairman, before I
Pardon me?
relinquish, can I ask one?
Can I just ask a clarifying
no,
question before you
you're the
continue?
boss.
Can you tell us exactly what she's contracted to do? Because I have the contract and it's a lot. But what specific services are they providing?
Well, Tiffany might help me with that, but they have treatment. I mean, the
But
primary things are.
specifically, what kind of treatment? What level of care?
Can you answer that? Okay, thank you.
Because again, I think that makes a difference where somebody goes versus doesn't go, correct?
So Jana is contracted to provide intensive outpatient. She's also the contracted provider in the county for partial hospitalization. We have to have a contract for every level of care. She is the only one that we contract with for partial, and we actually haven't had many referrals to that service. We contract with her to provide level of care assessments. So if someone needed outpatient treatment, they could just walk into our agency and get that. And then we have different recovery supports that we contract with her for outside of treatment. There's a codependency group that they contract with her for. She also oversees our recovery center in the Slate Belt called A Clean Slate. That she has that. And then there's just a few little pieces. She receives funding for adolescents in the schools. She does some group called, I can't think of the name of it offhand, but she does some student groups at school, which is something that most of our outpatient providers do not do. So she's one of the few that gets funding for that. And I believe that is everything in her contract.
Okay. And the other question I had was the process of funding/audit. So at what point, like, do you audit every provider, or do you follow through to make sure they're doing what they say they did in the original contract?
So every year we have to monitor, our SCA monitors every provider that is located in our county. If they're located outside, like we contract with Mid-Atlantic Rehab, but they're in Lehigh County monitors them. We look at session notes, make sure they're doing what they're doing. We compare to invoices. Our fiscal officer also knows the contract, what we are contracted for, and then monitors the invoices that are coming in. We don't pay outside of what's in the contract. We have it very specific. When Tabitha and I were in charge of drug and alcohol, we changed the contracts. They're very specific. So that really you can't bill outside. There was really no wiggle room that someone could say, well, my contract's written for this amount, so I can just spend this much money. It was specifically designated for these different pots. So that's audited, and then they obviously do their financial audits they have to submit. But we do an annual monitoring of her every year.
And all providers.
All providers.
And about
but
what time of year do you do the auditing process?
It's typically April or May. It's due into the state in June. I think last year we did it in the end of April.
They're scheduled for, the bulk of them are scheduled for April and May of this year.
And the contracts are awarded July 1st?
They start July 1st. They, I believe, are already going out their packets, and every year the packets go out, and the providers can submit proposals for any programs that they want to offer, and then we look through them, say how much funding we have available, make sure we do the necessary that we have to have, our treatments, and then we look at recovery supports, what services are going to benefit the county. So obviously our recovery centers, Jana put in for her codependency groups, her lunch and learn. So those are things, if we have funding and we see the benefits and the outcomes that she submits on them, then we have it, we have added it to the contracts.
I don't want to hog the time. I'll ask more. Go ahead.
Yeah, so a couple issues there. So one, I want to thank you for the letter. I mean, I think our residents and vendors should at least be thankful, whether or not they like the answer or not, should be thankful for the effort and the time spent on their concerns.
Thank you.
Thank you. And then, so I guess going off the audit first, have we found anything odd in the audits there? So I mean, are they just going over the money because of there's just that much population that they're putting through there, or are there errors or problems in the audit that they're going through the money?
You can say up here.
Sure.
We're required to do audits for all of our.
Sure,
vendors,
yeah,
right?
absolutely,
So
yeah.
it's not. It doesn't mean that there's a problem or not. Specific to her audits, I don't know if Tiffany can speak to.
It's standard, so I don't know that there's been anything that we've found. Tabitha is just, everything's by the book, so Tabitha scrutinizes it as it comes in, so.
So them using the money, it's just the amount of people that they're pushing, getting through there or going.
Yeah, are you asking why they've run through their contract so fast?
Correct, yeah.
I don't think there anything, they might have had an influx of people who didn't qualify for MA that came through there. Some years they have more people who have MA, so they might not use the county dollars to fund the treatment. It really just depends who's coming in. Treatment's supposed to be individualized, so not everybody should get 2 hours a week. So if their kids, if people were getting more treatment, they might have used up more dollars that way too. It's hard to say because I don't know the individuals that are getting the services.
And I'll tell you that for February's, are we in March already? March almost over, I guess. February's invoices, in fact, Miss Morris's invoice was double. It generally runs about $5,000 a month. It was 10 or 11 grand, and I asked our accountant about it, and she said it seemed like folks who were coming for, I think she said group sessions, were coming, the same folks were coming maybe twice as much as they used to. So whether that was, they were encouraged to come more or whatnot, I don't know. But that was a spike. But for what we can tell, certainly appropriately spent. I know there was some concerns when Tiffany and Tabitha took over the division. And Tabitha made some pretty significant changes with pre-authorizations to get folks approved for services and changed the way invoicing was completed to actually include client identifiers so that we could ensure that all of our providers were not in some capacity double dipping. Mm-hmm. So anyway. Yeah. That's what I have on that.
And then the second part of that is if one location runs out of their funds and the audit shows that they're doing anything by the book, at least, if we have another facility that has funds left over, is there a way to share it or send it back, just?
Yes, absolutely. So, ultimately, this time of year we're really looking at that. And so it really just depends which division, which provider, which services that folks are in need of. But we try to share the wealth, too. So before we allot any one provider additional funding in a contract year, we try to ensure that folks have opportunities to seek treatment other places, too. But again, if somebody really wanted to go to Recovery Revolution, I don't think anybody at the county would say, we're not paying for that. We just wouldn't do that.
Okay, thank you.
Sure.
Any other questions? Go ahead.
The county has had a history of managers at times, in human services particularly, and I think Ms. Hefner and I had a discussion about this. It's like a two-way street. It's good to have relationships with vendors. You get to know them. They get to know you. At times, though, that could go the other way. And there would be this idea where we just keep the same vendor over and over and over again. And sometimes we always had to do audits, but the audits were pretty, it was like, hi, are you there? Your office exists, thanks.
We're a little more detailed than that.
Well, I was going to say, I think that it's important. I mean, and that's been a long history.
Sure.
And it's not everybody, but there have been. Sometimes the relationship can go a little bit more than it is. I wanted to ask you, and I mean, the idea, though, of also I mean, you would probably see this with other contractors, and we had that even within, like, children and youth. We can only, our budgets, you could probably, I'm sure the need for even this program, despite her complaints, we could probably spend more money and run more people through, but we just can't afford. I mean, we could do that with probably most of the vendors in human services, I would think.
Sure.
So we have to have certain limits. Yep. She did specifically mention one place, and I don't want to get into specifics too much if it's a problem, and you guys know what you can say and what you can't say.
Sure.
She mentioned the slate belt folks were getting a raw deal because of, was it a clean slate or something, a new facility or
no, that's the recovery center that Jana does run.
We added there was something she complained about.
Is a facility that we contracted with. It's a newer contract. They're further north, right? Okay. So you obviously saw her thoughts on that and my response. So, but the slate belt isn't just Bangor. Yeah. And it's not just Bangor where Recovery Revolution is. The slate belt's bigger than that. And so, and Pyramid Bartonsville is now our only provider, to my knowledge, that is willing to provide and able to provide regular transportation. And so we do have folks who are inpatient there, and it's a natural continuum of care for them to remain there. But again, ultimately, this is the consumer's choice. So if somebody wants to go to Pyramid, fine. If they want to go to Recovery Revolution, fine. If they want to go to Lehigh Valley Drug and Alcohol, well, that's not a treatment provider, but they have the choice, right. And we respect the choice.
Do the individuals in drug and alcohol, do they get like a waiver that they can take anywhere they want?
So when they go through, we contract with Lehigh Valley Drug and Alcohol Unit as our centralized intake assessors, and they do not do treatment. They only do assessments and case management services. So when a client goes to them and they have an assessment, that facility provides the name and contact info for all outpatient providers. So if the person's assessed to need outpatient services, they get the 4 outpatient providers in Northampton County. Ideally, they're walking out of that facility with an appointment already at one of them, but if not, at least they have the information with them, and they know it is their choice to choose whichever one of the providers that they would like.
And this is my last question. Have we had,
famous last words?
You know what? I don't dislike what we do. I've always been affected or afflicted with the need to know why we do some things and how, and that doesn't always work with being brief. So it's just a matter of personal
Mr. Heckman. It's all right.
Bottom line is, have we had any complaints from consumers?
No.
I mean, other than people will always wish they might have. I'm talking about specific complaints.
And
that's all I wanted to know.
We do not, and I will tell you because that's often the Ms. Morris will, pick 5 stories of significant complaints. And look, there are people who are going to be unhappy various places. I get that. We have not received any, and for just as many folks as she has complaints for, we have folks who left there to go elsewhere and have complaints. And that there's complaints about every place. So, yes.
Thank you.
You're welcome.
Can I just have one quick comment, which
You're sounding like Ron now. Go ahead. No.
But just that, I do want to point out that, that you will fund it if a patient wants to go somewhere, because I do feel that, it's the patient's money, it's the resident's money, it's the patient's money, not the facility's money.
I think that's a very good point, Mr. Dietz. Absolutely.
I guess my concern when I read this is a couple of things, is that the allegation that we're denying people treatment, the allegation that we're sending people so far away when it seems like we're not.
Right.
The idea that I guess the thing that bothered me the most about receiving the letter is knowing that the funding cycle is not even up yet, and that it sounds like the letter alludes to the fact that you chose not to give her money when she has a contract for this year. And so there's nothing at this point that would keep you from considering a valid RFP for the following year, correct?
Oh, absolutely. Absolutely. That's
But
where we're
what
at now.
concerns me is also there is something in here that says that she had not been in agreement with DDAP auditing requirements. So do we need
So
to
the
speak
brief-
about that or
I'll
not?
give you the brief. I'll give you the really abbreviated version of that. There's electronic computer reporting that is required for drug and alcohol assessments and treatment. The one that is required for assessments is considered a case management function. Jana's office, Ms. Morris's office, does treatment only. So our office could do the case management. Lehigh Valley Drug and Alcohol Intake Unit does case management. Ms. Morris seemed to be confusing the laws regarding confidentiality for case management services versus treatment services. I do think after quite a few months of problems, and that was the entire reason she did not get to be part of the grant that we just received, because at the time that we had to award the grant, she was still not in agreement with completing the reporting requirements. And we can only work with contractors or with vendors who can meet the state's requirements that we have to enforce. She has since reported compliance, and I have no reason to doubt that when we go to monitor her, we will know that. So if she continues to be willing to meet the requirements of the state, we will continue to contract with her for services. Did that answer your question?
Yes.
I forgot what you asked. Sorry.
But so she's basically not being denied funding. She's
Nope.
being denied additional dollars.
Correct.
And she's still eligible for future RFP
New
applications.
funding cycle starts July 1.
Okay.
Right.
And I guess my last thing is, because she sent us some evaluations, but they did not appear to be evidence-based to me. So is she required to do evidence-based by DDAP or by you, or is, what kind of,
Her programming is all evidence-based. I don't know that her status, I don't know if they require their satisfaction surveys to be anything more than whatever they decided.
I like it, I don't?
Correct.
Okay. Because that seems to be the standard of care, is evidence-based all over the place, so. Okay, so we're not denying treatment to the slate belt.
We are not.
Okay, thank you. Glad to hear it.
welcome.
Glad they still have, they have a recovery house, right?
They have a recovery
center.
center, yes. Yes, she
Okay.
does.
So then we're good? Let's move on to
Crystal.
Director of Humans. Do you want to do the Graysdale next, or Human Services report? Do you want to do Graysdale next?
Yes, we could do Graysdale. And I know we had a couple of follow-up questions from Mr. Warner last month, so I know we are prepared to discuss those tonight. So, Jen and Dawn, I will turn it over. No, 2 weeks ago? Sorry. Time flies.
It's all blending together, isn't it?
Color and line. You know, we'll have a contest to change it from dashboard, and we will give something to the person who comes up with the new name. I have to think of the prize first.
The informational dashboard, got it.
Hello. So we'll start on the second page, which goes over the average daily census, which is 662. It is lower than our budget of 665, and you can see below when we had the discharges, we had 33 admits and 43 discharges, so that took a little turn. Usually in the wintertime, we always do hit 1 month that devastates us a little bit. So unfortunately, February was the month for us. Our average PPD was 3.41. So I just wanted to give you something from last year. February of last year, we were at 2.91. So we have come a long way since last February. And with that, that means when we did the calculations, we have 59 more people per day in staffing. So the cost per resident day, I don't have those figures. We're waiting for those monthly final bills to come through, so I'll have that for next month. And Medicare numbers will also come with that. So again, you can see we had 142 inquiries into admissions into Graysdale. We took 33. And then you can see the discharges, which equal the 43. You know, they went to hospice house and so forth. When you're ready, we'll flip over to the next page. We have the agency costs. Again, I don't have for February because we're waiting for those final bills to come in from the agency usage. You can look at January's because last month I had December's. So January's numbers were a total of 304,723.05. And that correlates to the hours of 7,330 hours. And then we have some pie graphs for you. You'll look below that and we have staffing numbers. And those are the vacancies, again, based on full-time equivalents. So for CNAs, we have 88.4. LPN is 30.9. RN is 36.2. Dietary 6.7. Laundry is 3. Housekeeping is 2.1. And then hires during the month were 11 and terminations were 16. Again, we're still feeling the after effects of those per diem people that never came anyway, so we had sent them letters to say, you know, if you can't meet what we need, then we're going to voluntarily let you go. So then we get into the call-offs, which Mr. McClure had already alluded to. So the total call-offs were 599. So that breakdown is 59 absent calls, 2 absent no calls, 20 absent weather, 2 approved absences, 5 bereavement, 49 emergency personal, 1 emergency vacation, 3 family sick, 7 FMLA, 180 IFMLAs, 11 no call no shows, 1 personal, and 259 sick. So that leads to the 599.
Do we have an auditing system to validate any of that? The call-offs and stuff?
Yes.
Except for the IFMLA.
Mr. Dietz, that question is better directed, I think, to Human Resources, and Ms. Kelly is looking into that specific issue as we speak, and she'll have an answer for you about that. Sorry, Jen.
No. So if you flip to the next page, we talk about the wounds. So we talk about in-house, we have 29. Wounds upon admission were 7. Acquired while at the hospital were 5. The total wounds for the month were 92. Healed were 21. Expired or discharged were 17. So we are up 1 wound up from last month. So we have 54 total wounds in the facility.
Can I jump in here and
Absolutely.
ask a question? Because I thought we started to talk about severity of the wounds. I mean, like, I know all wounds have to be reported, but I know that there's different kinds. Like, there could be a scratch versus, like, a sore. And so is there any way to distinguish how you report, like, the level of severity of what you're seeing? Because the number is pretty inflated. And when I see that, I think they all have bed sores, you know? And if that's not fact, then maybe we should correct that misperception.
And it could be multiple wounds on one person. So again, somebody...
And they could be coming in with these wounds as well.
Well, that's 7 of them came in, right, on admission, and then when you send somebody out to the hospital, 5 more were acquired at the hospital. So, right, there's a little less requirement to move and reposition people at a hospital than you have at a nursing home. Just looking for the wound data. There we go. So for the stages of the wounds, we have 3 on stage 1, 24 on stage 2.
You want to say what stage
Yeah,
1,
sorry.
2 is for those lay people of us that don't do wound
that's
care?
me.
Well, I will ask my director
I don't
of
do it
nursing.
either.
Explain the stages, or?
Sorry.
That's okay. For the stage 1, those are more pressure sores. Those are if you're lying on a bony prominence, if you're, you're not being turned enough, if, it's not open at that point. The stage 3 and 4 are more severe. Those could tunnel, which means they go deep. It's not just removal of the skin, but they go deep down. So those are 3 and 4s, and those are what our wound team follow up on. And then the stage 2 is that in between in there. It is open, but there's not, there's no tunneling for that. So the wound treatment team that we have, they do the 3s and 4s, and then the nurses take care of the other 2. If they need the treatment team, they can come, but the nurses are very qualified to tend to the wounds.
So can you do the numbers again? Sorry. Thank you for that.
Sure. So I said stage 1 was 3, stage 2 is 24, stage 3 is 17, stage 4 is 13.
May I ask a question? Oh, no, was that you were done
That
with
was the 4 stages.
Okay.
right?
This has always been a concern for me.
Right.
More than is it fair to say that stage 2, where there's no tunneling or whatever, that if it's not treated promptly or well, it could roll into stage 3?
Correct. Stage 1 can go to stage 2, stage 2 can go to stage 3. Yes, it goes up.
Have we been going, I know there was talk about training and.
Yep.
Is there a lot, like a follow-up and I guess I'm asking, are we really on this open wound issue big time?
Yes, and the
Layman.
LPNs, I think Candy is now up to 30% maybe. So last month I reported 22 maybe. But she is now up to 30%, and she's really trying to get that number up. To take them off the floor for to follow them is a little difficult at times. So it's a slow process, but yes, we're definitely moving toward that.
Thank you.
You're welcome.
And we do have training coming in for the floors. Like we just had Medline come in. They went around, remeasured anyone for their briefs to make sure that, they're the right fit. We have the wound company we use will go around as well. The products we use, we make sure that they're top products being used now. So we're constantly looking at this, and we have re-education. We keep bringing it back in. So that is one thing that we are on top of, absolutely. So the next thing are the reportable infections. We are down this month. So there was 87 total, 3 present on admission, and 26 required reporting. And then monthly incident reports were 353, so we are a little bit up.
What qualifies as an incident report?
Glad you asked.
I hope I'm not being redundant, but I think we use this language, and then, what
No, I
I think it
appreciate
is probably not what other people think.
Yeah, no, I appreciate it.
Well, right, because it could be anything. It's
It's an
between
incident.
residents. It's all.
You looked at me funny? I have to write up an incident report? No, but in a hospital, there's all kind, they go write it up, so.
I think we're going to label these next time.
Oh, that's right.
Because someone says it.
Yep. Okay, I'll keep looking up that one. So then the falls were 169, which came down, so that is good news. The falls team is actually meeting now. We have them in place, and they are working diligently on the project we have. It's actually one of our performance projects, so we are looking at it at our QAPI meetings. It's a huge undertaking, and we have 2 people who are really good. Kirby and Wendy are just throwing themselves at getting these falls down. And then we did have the 2 state visits for February, and that was the revisit that we had in February, and a complaint which was unsubstantiated. And then we brought back some of the quality measures, which is on the next page. So you can see there's 3 red ones that we are looking at, and those are the items that we are seriously taking a look at. We're looking at everything, but we know that pain is always an issue, and we are working on a new pain committee and getting our pain numbers down. And then the antipsychotic medication, obviously we've made some great strides since the state recognized us, and we are continuing to work on that to get it down even further.
And in terms of the residents who received an antipsychotic medication long-term, does that fluctuate because of who's admitted on them, or that
Right.
they're sustaining the need for that, which obviously at their age and stage of life, they probably will continue to need it, but...
And you have to remember who we take. I mean, we're the county home. We take those that need us. You know, we're not selective. We don't cherry pick. We take our people that have nowhere to go. And sometimes it comes with the medications. It comes with all the things that they need. So, you know, if we're a little higher than other places, I'll own it.
Again, it might be helpful to break down what those are, because when you see that, like, again,
there's some information that we have to be very careful on giving out.
I understand,
Yeah.
but I'm just thinking, like, if you say the name of a certain medication, or somebody's been on something for so long,
Right.
it's like, like, I might know that that's something you're going to stay on for the rest of your life. You know, like it just, or that maybe they decreased or stabilized dosage. I think some of that information might be helpful, rather than just saying they're all on antipsychotic meds, like a headline, you know?
Or if they were brought in on it, you know, so it's not something we started increase of it. It was something that they
Right.
were on when they were brought in.
And we constantly have to do. I mean, the state looks at us and they tell us we have to look at gradual reductions. We have to do that. So our pharmacy works with us on looking at who do they think might, you know, benefit from tapering it off.
Mm-hmm.
But you also then have to watch. We taper it off, you see, and if the behaviors escalate, then you just got to go right back on. So when we do, and what if we can justify it, they stay on it. But it's something that it's
What are all the symptoms that we're treating with the antipsychotic? So, I mean, is it...
behavioral. So you have a dementia unit that can be very aggressive. You know, you have people striking out at each other. Sometimes they beat up on staff. It's...
Well, I'm saying, so someone with dementia, I mean, the reality of weaning them off it is probably not...
Right. But the state really doesn't care about that. They want to see something that you're at least attempting it. They don't want anybody snowed so that they're lying in bed and there's no movement in them.
Right.
And then we have schizophrenia. We have depression. We have all of those things. Yeah, bipolar, anxiety.
But there are some people who are not psychotic who are still given the classification of antipsychotic meds because it's the most helpful for their sleep. And so, again, it's a little misperception, and that, you know, if that's the best thing to help them sleep and get, you know, good rest so that they aren't bipolar or cycling or depressed, then they should be on it. But
Right.
and at what dose? Are they at like the best threshold dose for treatment? They're not at these high levels of...
Right, and you can't. And that's something that the state looks at. When they come in on a visit, on a complaint, they are looking at all that. They are looking at medications because that is the first thing they look at. They do not want a place where people are zombies.
Right.
And this may sound like a foolish question, but
apologize.
are there improvements that can be done to the building or the rooms themselves? Like,
Yes, and we're working on that.
to reduce that, we can only train the nurses maybe so much or do something, but at the facility or the room that they're in.
Yes. So one of the great question, because I've actually just went to my staff today, and we are setting up stations on one of our units, and one of them is going to have a crib, a changing table, a dresser drawers. We're going to put baskets of baby clothes on the desk. We're going to get tabletop boxes that have just old pocketbooks in them, you know, scarves, hats, things that occupy them, busy boards, you know, and by no means is that any kind of, it's total dignity is always our foremost thing that we're going to be looking at. But yes, these are the things we're doing. Somebody asked for a quiet place on the unit, and I just saw we saw some board walls that are going to be coming down somewhere in the county, and we said, can we have one and kind of make an area where it's very quiet, so you don't see people pacing, and maybe they just want to go in there not to see the stimulation that's going on the unit. And then we are training the staff to see and recognize things and how to address them. And you know, if somebody's bless you. If somebody's coming up to you to, you know, saying they have to go home or they're waiting for the bus, to live in that moment with them. Don't fight them and say, well, you're not. You're in a nursing home. No, say, okay, the bus will be here at 5. You're a little early.
Yeah, 'cause you see videos like that, you know, where they bring plastic babies and they
have them, yes.
you know, they react to them. Or one of the places that I seen, they had like for the Alzheimer's, the outside of the rooms look like a small town, you know, so they feel more comfortable going in there. So like, you know, the room looks like it's a townhouse that they're walking into, or like a bakery or something like that, so that the hallway feels more like.
Exactly.
You know.
And down on one of our other units, we have a lot of clipboards. We have a lot of people that had jobs where they walked around with clipboards. That's all they want, and they just walk around. They make notes for us. They hand it to the nurse. So whatever it takes to make them calm. I'm looking at. We have a lot of those pets that sit on your lap, and that also leads to a deterrent on falling. If you put it in their lap, they're less likely to get up and move because they don't want to disturb the cat or the puppy. And they purr and they make noise. We've just ordered more taller dolls that maybe you're looking at a toddler size doll. So instead of just babies, maybe they have a toddler they can put in a high chair. So we're looking at different things to combat that behavior. We've asked before and we're not allowed, and this administration is letting us do that.
That's great. I think back to when my grandmother, she had fallen and was in a nursing home in New Jersey, and I'll never forget the room she was sharing with. The lady next to her had a stroke, and they had assumed that she couldn't speak or had issues, and it just turns like she forgot English and was actually speaking German.
Right.
My grandmother spoke German, came in and said, she's fine. She's just speaking German or whatever it was, and the recovery was, you know, outstanding.
Right, and you try to put so if maybe you have a German speaker, you get another one. You have to remember that, again, it's a 4-bedded room, so you're not dealing with a double or a suite or anything like that. You're dealing with 4 beds, 4 people dealing with the same disease in a room. May not know which bed is which, who's who, what's what. It can be challenging, and our staff is wonderful.
I agree with that. With everything. May I take it back to wound care for a minute?
Sure.
Was there ever a concern with consolidation of stage 1 and 2 wounds incorporated in with stage 3 and 4?
So what was happening is some of the nurses weren't trained on staging a wound. So Candy's been out and retraining, and that's how we're getting the LPNs in, so that everybody knows the difference between a wetness, reddened area versus the start of a wound. So we
So there was an overlapping of the wounds.
Right.
Okay. The other thing is the business of buying the supplies for the wounds. Okay, has that improved?
Yes.
There was a weakness, I believe, in some of the things that they were purchasing for the wound care, which didn't help us.
Right. It did not. We have, 2 weeks ago I met the woman who supplies us with items, and I do see what comes in, and yes, from our perspective, we are doing very well.
Can I expand on that?
Yes.
Even I would have to really look to see my notes.
Yeah, mine.
No, thank you. To see the timing, we looked at the undergarment that we were buying,
yes.
the creams,
Yeah.
and we had a long conversation about upgrading, and it turns out we were already buying top of the line products for those things.
Okay.
So there was no room to go up any further
That
on
was,
that part.
that's merely a question of
Yeah.
see if we could do
Nice.
better. But the other thing about the combining of the wounds was interesting. I didn't know that that had happened, and I wasn't sure if we had rectified that or not, so. Okay, thank you.
You're welcome.
Ron?
Oh, you had mentioned, I guess I'm going to go with the, we talked about the antipsychotic, and we've gone over this, and you mentioned tonight how we taking people, and we've discussed that on various occasions. And I understand you have to comply with HIPAA, and there are a great many regulations you have to deal with, federal and state. But is there a way, because as we go forward, I think it's going to be important for us to somehow chronicle. We all know, sitting here, and because you're telling us, and we see it, we go out, how we are getting a disproportionate share of folks who are at one end of a spectrum or leaning one way as opposed to maybe your typical nursing home. Is there a way, though, that it could be broken out somehow to give an indication? I don't know how to do it. That's why I'm saying, asking you if you'd consider it or look into the possibility of saying or giving us something that says, in our opinion, pure and simple, you're not making any law. Our opinion is these are folks who might qualify. Let's say the state hospital was still around.
Right.
They'd had levels of care.
Correct.
And at one time, that's what caused some of the problems. They would put people in that shouldn't have been in. But there were definitely folks who needed some of that care. I guess I'm asking that in a way of, if we take someone in that, in your experience or your expertise, that you would say, you know what, this would be somebody that would be seen as needing this extra psychiatric or care. And I know you can't do something that we can define who it is.
Correct.
And so maybe that's impossible, but I'm just putting that out there. That's all. I think it would be helpful for us as we talk to the community.
Right.
Because when people speak about Graysdale, most people don't know that. I mean, they say, hey, here's a nursing home A, here's Graysdale.
Right.
Why are you having a problem? I don't think they have the problem. And they don't understand our philosophy and what we do that you just clarified, as opposed to maybe another home that gives itself more options. So that's all I'm asking.
And I can tell
We
you.
don't pick and choose.
Sure. It just seems to me to be common sense, though. If you have a higher population of Medicaid, for example,
Right.
even at end of life, let's just talk about folks at end of life. If you were well-to-do throughout your life and remain well-to-do at the end of your life, you're still probably in better shape than the folks who were never well-to-do and are on Medicaid now. Okay, that's just the way our outcomes are with our healthcare system. So you can apply your common sense to that, but I think they can try and analyze that for you.
Yeah, I mean, maybe you can, maybe you can't. I guess I'm trying to put not a qualified, but a
quantifying number.
And it can't be accurate because it's impossible.
Right.
And I don't know if, like I said, I don't even know if what I'm asking can be done. So I'm just sort of throwing that out there.
I think some of that might be qualified when we look at how many patients we have are private pay and how many are Medicaid, Medicare. You know, if you compare that to what
Eventually they all tend to go Medicaid.
Correct.
I mean, even in the privates.
Yeah.
I guess depending on, we could say who comes in as a Medicaid.
But you also look at that. A lot of times when they become Medicaid at a private, that's when we get a phone call.
And they come over. Yeah.
Wait a minute. Whoa, let me back up on that. So I'm sorry, Lee, but I have a question because this is one that confuses me a little bit. They're already in a private home. They've been accepted.
I get that.
And they run out of money. And now they've got to go on to Medicaid.
They go in there at short term.
Do they go in with the understanding that once they run out? I mean, they can't, if they don't tell them up front. I can tell you there's a prominent home in the county that has assisted living and a nursing home. They have a policy that even if somebody's in their assisted living, just so you know, you can come into our home, but when you run out of your money or private insurance, you got to go. But if they don't make that clear, then I thought that's illegal.
You're right. If you are duly certified Medicare, Medicaid beds, it's very hard. But there are homes, when you're going in for short-term rehab, I don't
Oh,
have any.
short-term rehab. Okay, I'm
Right,
sorry.
you get them in going,
clarified
but
it.
you get them in going
Yeah,
short-term.
I hear you. Okay. Yeah,
And then
because
it's,
you get
well,
how
we
many
don't
days
have any
Medicare you can.
Medicaid beds available, so.
Yeah, because they're going for the Medicare dollars, and they could do that, and then at the end of that, they can say
Sorry.
you leave. Yeah, all right, now I understand.
grant them extensions.
Well, we do.
What we do,
Yeah.
But other facilities may not.
Yeah.
All right, you've
Correct.
clarified it for me. I thought they were literally there, and they started getting off, and they said goodbye, and I'm thinking, wow. You can't even do that in Florida, and I think that was the test case.
No,
Thank
but they're
you.
very strict. If they say short-term, you're here only for short-term.
Okay, thank you. Yeah, you clarified it. I'm done. I'm finished.
But will they only let you stay short-term because they know that your money's gonna run out?
Correct.
See?
We have families that come in crying,
No.
you know, and we do, my team does a great job. I mean,
I think that's how you get some people, because they may have money, but they know if they go into this place, they're gonna have to leave.
we've had
So they might as well
residents
just come to Grace to
wheeled
begin with.
into the lobby and left.
That's horrible.
By the way, that
What, you mean
happens
the
at
person who
privates,
wheeled
too.
them
I've
in
talked
just
to executive
leaves them there?
directors. A
Drop off.
wheelchair is parked in front of the doors at other nursing homes too, and they find this person sitting in a wheelchair.
Right.
That happens all too often.
And we get calls from aging. You know, aging's doing a protective case. They call us right away. We make it happen. They get a bed right away, no questions asked, because there's nowhere else.
Well, I mean, but it is what it is. What it is. I mean, I think again that clarification helps to highlight that when we're talking about how bad things are, that we're really doing very well with the level of functioning of the clients that we serve, and
Right.
you know.
It's very hard to
I
compare.
mean, you have
us.
some tough cases. And even somebody made a comment to me recently, even about the behavioral health clients that are coming in. Because again, these are people who historically have probably not had great behavioral health care ever in their lives, or not for most of it. And then they're coming in and they're finally getting care now, so.
Right. And there's other things wrong. There's other comorbidities that they're coming in for. So it's not just mental health.
Yeah, it takes a toll. Did you want to speak to the behavioral unit again? The Haven House project, how's it going? Any upgrades?
It's going great. They're up to over 30 people. We have residents that are thrilled to death. They just absolutely adore the workers at Haven House. They enjoy the time because it's an hour or 45 minutes of pure conversation with them. It's not a timed, I only have 16 minutes for you. They're here to hear the resident, to give them that one-on-one care, and that's priceless.
Are they also doing training for the rest of the staff, though? My
Yes.
understanding is that was part of the
Yep,
grant.
they are,
And how's
absolutely.
that going? How's the
Good, this
staff
month-
responding to that?
It's good. It's another outlet. You know, they are. We actually have someone who's going to be stationed on one of our floors to kind of help navigate some of the issues that are on our particular floor. Just to be there if anything happens and how to de-escalate the situation, because you're dealing with dementia.
Any other questions on Grace?
I do have the incident reports if you'd like.
Could you let her finish that before
Sure.
I ask your question?
All right, so with those 353 incidents, we had the 169 falls, so those falls count towards the incident reports, 1 elopement, 20 assaults, resident-to-resident assaults, 5
Slow down,
resident-
slow
oh,
down, slow
sorry.
down.
It's that New York coming out.
Yeah, but my pen is in Pennsylvania. Go ahead.
So we had the 20 resident-to-resident assaults.
Right.
The 5 resident-to-staff assaults. 1 choking issue. 61 incidents of unknown origin. So that could be somebody just has something show up and nobody knows where it came from. 11 medication errors. 2 medications unavailable. 1 missing Medicaid patch. 30
Wait, 1 missing Medicaid patch? What?
medication patch.
Oh. Okay.
30 accidental self-injuries. So that could be somebody in a wheelchair and she might be wheeling and they get stuck or something. 9 accidental staff injuries. So if one of our staff gets hurt, then that's still considered an incident report for us. 12 missing properties. So that could be hearing aids, dentures, could be anything. Eyeglasses. 6 transferred out related to an accident or injury. 1 equipment failure. And 24 other.
Okay. Mr. Giuseppe?
Yeah, I just wanted to double back to the issue that Mr. McClure raised at the beginning of this meeting, and that was the FMLA, IFMLA situation. That is not a new issue. The previous administration and HR director attempted and made a little bit of headway with that, and I believe, as Mr. McClure does, that if someone is entitled to it, they should take it. However, we do need to check and make sure that in fact they are truly entitled to it. But the other thing that has been an issue in the past, and I haven't heard it brought up at all lately, is workman's comp. Do you have any idea how many employees are currently out on workman's comp as part of the?
I don't, but I can get that to you.
Okay. Well, thank you.
Comment.
Yes, Bill, go ahead.
Back on Mr. Heckman's comments, I'd just like to say, you know, that is, you know, where are they gonna go? The folks, there's not a state hospital anymore. They're going to their prisons or they're gonna end up in your facility. So that does add more burden that, you know, and where, there's nowhere for them to go. That's what makes Graysdale the gem. If you have nothing, at least you have a place to go. And some of these people don't even have family, right?
Nope.
So that's where you get the wheelchair coming in, or, you know, so.
I have one that thinks I am his family, and I'm proud to say it.
Thank you.
Okay. We got her.
I'm
Moving on from Graysdale?
I thought, are you going to answer questions? Is that what we're going to do? Did you have?
Well, I have Dawn, who was going to discuss the position control.
Okay, can I ask about staff yet? Or is that should I
actually,
wait?
she'll discuss
She's going to do that? Okay, I'll wait.
Wait, the ghost of Florida just got here. The ghost of Florida
who is
past
that?
just got here.
And your name?
Kenny has a better stand than you.
Oh.
He was in the Bahamas.
Welcome back. Geez, does it, you get the
Try to
draft?
sneak in, huh?
Stop the
Not
draft
gonna
from the
happen.
back room.
Not with this crew.
You old snowbird.
That's fine.
Of course, she wore the white to
So are
highlight
we
the
doing,
tan, too,
we're
right?
still on Graysdale. Florida.
The staffing.
Go ahead, Don.
What questions do you have? The position control, what we've done, and we're just waiting for a few more details, is we've looked at every single unit. We've determined how many RNs, LPNs, CNAs, part-time, full-time, 7 to 3, 3 to 11, whatever shift. We've broken all that out now, and so now we know where our needs are, and we are working with HR and administration to get those posted. Apparently there's a new process as well, so they're all going to be on the county website, so you will start seeing all of those. This is something new for us. And I also want to bring up the fact about mandation, which, is that what you guys have?
Act 102.
Act 102. Act 102 is when you mandate somebody to cover a hole in your schedule.
That's correct.
So we do not do that. We only mandate if we've received call-offs and cannot fill them. For example, we get an IFMLA an hour before. Somebody calls off sick an hour before their shift. So we have mandated, if you want to take a look at that, we have mandated a certain amount. And when we mandate, I also put on that schedule how many call-offs we had, because I think that's very important to know. And we do keep track of that, and we are working with one of the unions to make sure that we are all on the same page with how we track it, how we mandate. But I know that mandation has come up, and Act 102 has come up. We have not violated it. I'm very well versed in 102. So we do not.
Is there a grievance?
On
Act 102.
on Act 102 for mandation?
In any union, or is there a grievance?
Yes, but it's on the disciplines that we've given out.
Okay, let's go back to that if we may,
Sure.
then we'll talk about it, because that's why I brought up Act 102.
Sure.
If you, according to what I know about Act 102, and I wrote it down, I was taking notes and I put them down somewhere where they are.
Oh, I'm sorry.
No, I just asked a question. I'm not going to talk
wait,
about
wait.
it, okay? I just wanted to clarify that there was something, okay? The second question is, now I'm not going to talk about that. Second question about Act 102 has to do with discipline, because under my understanding of it, okay, you cannot discipline a person if they refuse let's say a double, okay? Now, that's my understanding if it's according to the law from what I read, and I got an opinion from the unions on that.
So is there a question?
That question is not, it's very general, okay?
Well, no, seriously, I don't understand, is there a question? Or
I
is
don't
there
know
a
if she's
comment?
allowed to answer any of that.
If there are disciplines involved, and we're following Act 102,
She can't answer any of that.
she's not,
I can give you an overview and Dawn can fill in
go ahead,
the blanks.
go ahead.
There is a policy that Dawn is better versed at than I am.
Okay.
That covers when you can be disciplined for refusing mandation. And you can't be disciplined if you're being mandated inappropriately to fill gaps in staffing.
Yes.
Which is, we are not doing that. But the discipline, there is a policy at Graysdale that we follow related to, what is it, your second refusal?
Right, you're allowed to refuse one mandation per quarter.
Okay.
So if you refuse more than once per quarter, then there would be discipline, which would start off with just a conversation and, what's
Okay.
going on and proceed from there.
All right, let me read you my understanding of Act 102, and then we'll talk about what your policy is, okay? Act 102 will not prevent an employee, and this is right from the Department of Labor and the employees covered under Act 102 law bargaining purposes. Act 102 will not prevent an employee from working more than an 8-hour shift if the shift is agreed to and regularly scheduled, okay? It does not prohibit overtime for on-call overtime if certain unforeseeable emergent circumstances come about. Totally understandable, okay? This is the part that I guess I want clarification on, okay? And, they wrote on both sides.
Saving trees.
Sorry if save trees, I wish, okay? The employees may agree to work any overtime, however, an employer may not retaliate against an employee who refuses to work overtime, period. There's nothing in there in parentheses or anything else, okay? An employee required to work more than 12 consecutive hours under Act 102's exceptions or who volunteer to work more than 12 consecutive hours may receive 10 consecutive hours of off-duty immediately following the worked overtime.
Ultimately, I don't know, if Dawn can't, I was gonna say, that's really an HR question.
Okay,
And the policy is
But
certainly
wait. Is there a question? You read the act.
I read the act for clarification.
You're asking if our policy
I'm
meets
making
those
sure that the
guidelines?
policy meets those guidelines. How's that?
So that policy has been around for a long time.
2009, July
and
1st.
And never enforced until, I think it was the summer, it probably wasn't until the fall, if I'm not mistaken.
July of
late-
2009.
No, but I mean, so it had not been followed, so we worked with HR and the unions to, now my memory gets a little fuzzy here,
That's
but
okay.
to,
No.
basically to make sure that we were giving them their 90 days notice, to let them know that this policy exists, we've had it, but nobody's been following it, and we're going to start following it now. But we're giving you 90 days notice, because past practices, we didn't follow this policy. So we worked with HR on that, and Liz will have to speak to that, I can't, but.
Okay, so this was you're saying this has been implemented?
What?
Your new policy
No,
has
it's not a
been-
new policy. We're enforcing the policy that existed.
Okay. All right. Well, it still says that healthcare facilities had to begin compliance in July 1st of 2009. Otherwise, the Department of Labor and Industries Bureau of Labor Law Compliance enforces.
Well, I'll have to let Liz answer that. Liz and Ms. Kelly and Mary Lou Caboli were
Okay.
heavily involved in that, so. I
Well,
certainly
you
have to
understand
defer
my
to-
concern when the word discipline came in
Sure.
and the word mandated came in.
And I don't have what you have in front of me, Mr. Warner, to know if that's well, I'm not a lawyer either, so.
I'm not
that's
either.
why I defer
I'm
to
just-
the lawyer in HR.
I'm merely pointing out that you operate under Act 102, correct?
Yeah.
Thank you. That's all I needed.
Okay. Anything else?
No?
Okay. Anything else?
I don't have anything for Grace. I think we're good, yes? And we're going to run out of time
Well,
for
I
you
do
to
have
give your
some,
report.
I promised just one thing. I'm going to play Mr. Heckman, just one more.
Well, wait.
Okay.
Do you have a long report, or do you have something you could send us in writing, or can it be tabled?
My report was, you already covered Recovery Revolution, that was it tonight.
I got it, thank you.
I have some positive things to add, if you may. Okay. And the Act 102 was just a matter of information and research, okay?
We will get you that answer.
We talked about the staffing and people coming in for employee retention, okay? And I had a lot of discussion with a lot of people, and these people, the new hires come in, work for 2 weeks without pay.
You mean like every employee at the county where you
No,
don't
no,
get a
no.
paycheck?
The new trainees come in. Excuse
You're
me.
talking about the CNA program?
Yes, I'm sorry, yes.
Yeah, the CNA
CNA
program.
program,
They don't get
okay.
paid,
They
correct.
come in for 2 weeks and they
Yep.
work without pay.
Well, they're not working, no, it's a training program.
Bear with me on this, okay?
I will let you
The
finish.
if they're young and they have families and they're working for 2 weeks, they
Yes.
have bills to pay, they have things to do, okay? I'm trying to come up with a way that makes sure we keep those people
Yes,
who we're training.
agreed.
How's that? Does that sound better?
Yes.
If we gave them a training rate, here's the good part, okay? Have you discussed this?
We have talked about this.
There you go.
But it is, but just to clarify, so they're not working, it's a free training program that the Department of Ed funds.
Either
But
way, they're giving up their time.
Your goal is the same as
Yeah,
ours,
yes,
Mr. Warner.
yes.
The good folks who are coming through that program,
Yes.
we would like to retain.
Okay,
We have talked about various options. We've talked about paying them while they're there.
okay.
We have talked about paying them a bonus if they finish the training and get hired with us and stay for 6 months. So we've talked about a whole different set of options. The problem is, some of our problem is related to the Department of Ed requirements. So I don't want to misquote those off without having my notes in front of me, because it's been a while, but that was one of the first things I asked when I got there. You have people who are coming in here for 2 weeks. I think it's closer to 3, but I could be wrong. And how are they supposed to pay their bills?
I think
So
we talked about
figured-
investing a long
Yep.
time ago. We said, let's invest in quality staff. And
Absolutely.
it was either maybe a training rate, invest in them, or maybe once they're hired, then give them something after they're hired that makes it. I don't know what you would call it, because I'm not following that line of.
You have to be very particular.
Yes.
Right, and
But-
so yes, that is a conversation. In fact, Mary Lou Cavoli just recircled that wagon.
How about a reduced rate? I don't know what you call it, reduced rate or what, but my thoughts are,
Signing bonus, I don't know.
there was I brought it up. I said, look, we don't,
Yeah.
we're not hiring, we're losing them as fast as we get them. I'm sorry. And then how do we stop the bleeding? So if you look at the training programs and we can do something with that, it's a positive input.
Yep.
It's not I'm not being negative here. I'm just trying to.
You threw me with the initial working without paying people, because we
Well,
don't do that.
that's exactly the way I view it.
Well, we don't. So now listen, when you go to college,
We
when
could-
you
yeah,
go
we
to
could
college,
stop
Mr.
that.
Warner, you're not getting a paycheck to go to college.
No,
okay?
you
So
can't
it's-
compare that with that. I'm sorry.
Well-
That analogy will not
But
work.
I
No, I
understand what
think
you're
you
saying.
can
We want
at
to
some level.
retain-
You
In
can.
some ways, but.
Sure.
It really is, and I think
Yeah.
it's a public.
Paid to be a student.
It's a public policy issue, right?
Oh
Yes.
my God.
Do you, as an elected official, want to say to our taxpayers, we are going to pay all these people in the hopes, in a class of 12, we retain 3 of them, and you have just paid tax
All.
money to
Yeah, to
train
9 people.
CNAs for other facilities? So that's a public policy question, and reasonable people can differ about that. That's really what it's about.
Yeah.
So you want them to stick around.
Yes.
So could you
Yeah,
put
you
the
do, you do,
incentive
but-
on the tail end? Like you complete it and you stay with us for a
That-
year
that-
and we give you an incentive.
Those issues
That's a union issue.
are all subject to negotiation.
Right.
Yes. But I agree. I don't think we should be training people on the taxpayer dime if they're not going to stick around. We have
that's-
to ensure that they stick around, and it's
I'm-
not just
I'm in
by like
agreement.
increasing
I'm in
morale.
agreement with what Mr. McClure said. It just all comes down to the fact that there are people who have 2 weeks of no pay.
Right.
That's all.
You
And
can't afford to not.
they-
Yeah,
if you
I
can
understand
give
how
them-
that is.
If you incentivize them
Oh.
somehow.
Can we have one person talk at a time, please?
Well, yeah.
Thank you. Order. Let's come to order. I got 5 conversations going on in the room.
Well, I suppose that, if folks would agree to give us 3 years of their life for 3 weeks of pay, we could do that.
That's
That'll
what they
never
do at the
happen either.
seminary. When you go there and you become an MDiv, they'll pay your way through seminary if you give them 5 years in church.
Well, it does turn out that the Department of Ed does not allow us to do that because
There
that
you
was
go.
that was
Well, that's too bad.
That I know for sure.
So I guess I'm going to call this because
Yes,
I
ma'am.
don't hear a question, I do hear a discussion, and I
Yes.
guess the concern is how to retain staff, period, and how to deal with the CNAs and retain them during this training period, should it be compensated and or not.
It is my understanding that we are retaining.
that what I'm hearing?
Yes.
And listen. I
I
really
said-
couldn't agree more in principle with wanting to figure the same issue out. We are retaining certainly far more CNA trainees than we were a year ago. I mean,
Can we
classes
get
taken
some
used to
data
go-
from
Sure,
when we started the
absolutely.
training process? Who's retained, who's not?
Yep.
Who actually stayed
Well, that's-
3-6 months? You don't have to say why, because that's
No, it's
personnel.
just that's.
I can address some of that.
She can tell you some of that now.
She has some papers.
I do, because I like
Oh,
to be
you got
very
interrupted
specific.
with your thing.
That's okay. I just like to be very
She
specific.
got a folder and everything.
I have 2 folders.
There's some-
I
mean, I want to hear the info,
there.
but not.
The CNA training classes, we just had 6 week, they go 6 weeks. We just had 8 students that completed that, and we hired 7 out of the 8. The other one might not have been a good fit for our Graysdale. Last year, we've had a number of them, and I can tell you for 2018, out of we had 70 CNA students, 54 were hired. That's a 77% retention rate. But I must tell you, because it's a free program, they come, they get their education, they get their certificate, and they leave.
Well, that was going to be my next question. They do get a certificate saying that they are a trained CNA, that they
Yes.
can take and go anywhere else and get another job, correct?
We train them to sit for their certification exam, and we, at sometimes, actually allow them to sit, somebody from the Department of Ed comes in, they actually sit at our facility, with a proctor, of course.
That's awfully nice
So
of you.
we do that, but 77% have been retained for 2018. And again, I've been interviewing all of them personally for the last 4 months. Some of them I'm okay with not retaining, and then other ones just said, well, you know what, I'm not interested. I just want the certificate so I can go somewhere else. But it's a free education. So, that's all I want to say.
Can I actually ask a question? Yeah. So if you're training these people that are not going to make it through the program, or who are going to go someplace else, why are you doing that?
The trade-off. It's a trade-off. She just told you she retained 77% of them last year.
But already that you're not going to.
No, they don't always tell us until.
Oh.
They don't always tell us, well, I'm not really interested until the end, because they want that education.
But okay.
So it's a trade-off.
So you're not just training. You're not just holding a class for people to get their credentials and
Our
then
goal
picking
is to
from
keep
that.
them. Our goal is to keep them.
Or they get that bonus, that money as a bonus. Right. That's an interesting point.
It's free education.
Can I ask a question about that? So the CNAs that are there, you have CNAs that have been there for a decent amount of
Oh,
time?
yes, many years.
Beyond years?
Yeah.
What's their opinion about this? Because I'm sure they're the ones that are
They're
in the
picked up there,
trenches
aren't they?
training
Mm-hmm.
these people, and how do they feel about?
Some are excited because there's another pair of hands. Other ones there's a lot of questions, and they are busy. Our CNAs are busy, and they don't always receive them well because they're so busy, and they don't feel like they're, I guess, giving them enough time to train. And then others really, come on in, and and if somebody doesn't work out on one floor, we'll suggest another floor and say, hey, let's go meet those. And then we just did that last week. We just had one that wasn't very comfortable on one unit, and I wanted to retain her. We moved her to another unit, and now she's thriving. She's very happy.
I mean, but do they see it as a value add? Because again, I realize if I'm working there, I'm also now training this person. I'm investing my time. They may or may not stay. Do they see it as a benefit? Do they get annoyed by it? I guess that's.
They only go to the floors once they've completed their training. So once they completed their training, that's when they go to the floors. And then, again, they see if that's a good fit for each one. And if somebody says, that's it, I'm not staying, then that's when we talk to them and say, well, hey, what about if we
This
put you
floor.
on this floor or that floor. So we do everything we can to the ones that we're retaining.
Okay.
Do we need to revisit? Oh, did you have a question?
Couple things. Did you ever have a mentoring program, like the new guys coming on and be assigned a mentor to them? And the mentor could get a few
Correct.
bucks?
I don't know what they had in the past since I've been here, which is about 7 months. No, we haven't. I'm working with staff development about that, but because the staffing is not quite where we want it to be in that, we don't have permanent people on permanent floors. We still have a lot of floats and a lot of agency, and they're not dedicated. So the mentoring program, we're going to wait until we get everybody, well, a lot of people in place. And
Did you ever think of charging for this, the coursework of some kind of a small fee, and then have them get their money back with?
You can't charge.
Can't do that, okay.
Any other questions?
I think you're good.
Okay.
We good?
Thank you. I know, gather up all your papers.
Well, you know, we have another meeting, I hate to say. All right, is there anything left hanging out there in the wind?
Well, the only thing I was a comment real quick is I realize it may have gotten out of hand to reel it in, but not everything has to be a question. I do think that the conversation and dialogue is good. If it's getting out of control, it's one thing, but the conversations are good back and forth. Ideas, they don't necessarily have to be a question and answer.
Yeah, I wasn't understanding, and that's why I needed clarification. Was it a question, or were you reading it, and so to what end? That's what I wanted to know.
I was the one 2 weeks ago that questioned the staffing.
So this
And
was your follow-up?
This was a follow-up to say, you know what, maybe there's something we can do.
Okay, gotcha.
And final, Mr. Warner, when we get Ms. Kelly, we'll see if she can get this answer for you tonight, and if not, it'll be next time.
There's no hurry on that.
No, she knows
No,
this.
Brandon.
She knows this. I don't know it, that's
Okay,
all.
the guidelines are there, it's set for our government. It's in the program, and there's a period
Good
at the end of
times.
that sentence. Oh, yeah, by the way, we changed the policy.
I'm
Sorry.
gonna consult with my lawyer.
I'm sorry.
Are you're waiving your right to give a report at this time? I have an announcement. Due to a conflict on the third Thursday of next month, I'd like to move this meeting, and I've gotten some consensus that we're going to move it to the first Thursday of April, beginning at 3:30 for the month of April.
Ms. Vargo Hefner, just so you know, Ms. Stewart King will not be here, but we will certainly be happy to sub in for her. But I just wanted you to know that.
And I understand from her that it might be difficult to get a full dashboard kind of view of things.
You won't have that.
But if you want to take any of the issues that were highlighted tonight, and maybe we could expand on them at that meeting,
Absolutely.
that might be a reasonable use
Perfect.
of the time, if that's okay.
Yep,
I
we can do that.
apologize, but I'd rather continue with having the meeting and the reports, so that would be April 4th
Thank you.
at 3:30.
Very good.
And if you just email the dashboard later in the month when she has it, you have it, right?
Yeah, we can
Sure.
get that sent to Ms. Embo. Sure.
Anything else? I'd like to adjourn. I don't need a motion, correct?
Correct.
Let's adjourn the meeting. Thank you.
April 18th.